Intracoronary near-infrared spectroscopy makes it possible to identify lipid-core plaques. This is a well-accepted feature of this instrument. But the question that's often asked is, what is the clinical benefit? Now, a manuscript has appeared entitled Detection of Lipid-Core Plaques by Near-Infrared Spectroscopy Identifies High Risk of Peri-Procedural Myocardial Infarction. We will review the findings in this manuscript that support the clinical benefit of this device. This slide shows an angiogram of the right coronary artery with a proximal moderate narrowing and a more severe mid-narrowing. The angiogram shows the lumen, but it does not show the wall. It says very little about the composition of the wall, almost nothing about it. But in this patient, a chemogram was obtained. So at the site of moderate narrowing, there is a fibrotic plaque as shown by the red chemogram. The rectangle on the right shows a tracing of over 30,000 spectroscopic measurements made within the coronary during the pullback. The millimeters of pullback are shown on the x-axis. The y-axis shows values from 0 to 360 degrees. So it's as if the artery were cut open, longitudinally opened, and you're looking down on the lumen with the chemical measurement. The moderate narrowing in the proximal right coronary artery actually goes with a fibrotic plaque, as shown by the chemogram here. The chemogram is the red rectangle that shows the yellow spots where cholesterol was detected. The x-axis of the chemogram is the millimeters of pullback in the artery, and the y-axis is 0 to 360 degrees. So it's as if the artery were incised longitudinally and then folded open, and you're now looking down on the lumen of the artery. The chemogram value at the critical stenosis shows a massive lipid-core plaque is present. This is a completely circular plaque of lipid. The break in the yellow is due to the guide wire shadow. This is going to be dilated in a few moments in this case. And interestingly enough, the distal part of the artery, which you can see on the angiogram, looks pretty good, and a physician would be very pleased to tell the patient and the family that this artery looks good, is not so good after all. As you can see from the chemogram, there is a lipid core hidden in the wall. This is probably the kind of lipid core that caused the heart attack of Tim Russert, who passed a stress test and then died of a ruptured plaque. So let's return now to the stenotic area, which is going to be dilated as part of routine expected care. We all know that there is an incidence of peri-stenting MI, and it's suspected to come from these dilation of these kinds of plaques, which can embolize. So here is a picture of the artery, and the balloon is now blown up, and the result following the dilation with the balloon is not good. As you can see, there is no flow, and the problem here is not the lack of flow due to a large vessel obstruction. It's due to a small vessel obstruction because of the presumed emboli. This led to a very difficult situation in the cath lab, where the patient developed complete heart block, blood pressure of 30, CPR in the cath lab, and fortunately the team was able to bring the patient successfully through this. So what we believe happened, and what the authors believed happened, is that the dilation with the balloon caused a rupture of a lipid core plaque with distal embolization of the lipid particles and a secondary thrombosis distally. Now this slide shows the same chemogram we've been discussing that was associated with peri-stenting MI. Fortunately, this patient recovered, and because the patient recovered, there is no tissue evidence of what type of plaque caused this trouble. However, below this chemogram, we have a very similar chemogram obtained from our autopsy database that's kept at InfraredX. This chemogram, unfortunately, came from a 48-year-old man who died suddenly. You can see the lipid is circular right in the center, very, very similar to the cath lab case. Now, in the sudden coronary death case, we do have the histology. And the histology shows a massive, very threatening-looking lipid-core plaque right at the site of the yellow. And further down, there is a remnant of the thrombus that caused this sudden death. So in this one slide, we have the two problems caused by lipid-core plaques. On the top, cath lab complications. On the bottom, sudden death and myocardial infarction in the community. Now these are anecdotes, 2 cases, and it's always important to have larger numbers to establish a scientific fact with certainty. So there has been a publication by Dr. Goldstein in 2011 reporting on the results in 62 stable patients undergoing stenting. In this study, a large lipid-core plaque was defined as one that had a maximal lipid-core burden index in 4 millimeters over 500. What that means is that in a 4 millimeter length of the artery, more than half of it was yellow by the chemogram. This shows an example of a patient who has stenoses, is going to be dilated as normal, but there is chemographic information available. As you can see, there's a large lipid core at the site that is going to be stented. The stenting is done, the balloon is blown up, and a chemogram is repeated after inflation. You can see that the yellow is gone. Where did the yellow go? Well, unfortunately, this is the yellow that goes downstream. This slide shows the results in all 62 patients. So each chemogram represents one patient with a stenosis. The chemograms on the right show no lipid core. So these are fibrotic, calcified plaques, but they're still stenotic. The ones on the left, in general, show much more lipids. So these are a different kind of plaque. The vertical black line divides the patients that had a peri-stenting MI from those that did not. As is clearly evident, there is much more lipid core in the group that had an MI. The one exception, the bottom one, was a patient who had a defibrillator that fired frequently and may have caused a spurious troponin increase. So in general, a large lipid core, sometimes with a large arc, almost like a straight line going north and south on the chemogram, seems to be an index of patients who are going to have peri-stenting MI. This slide demonstrates the risk of peri-procedural infarction in patients with and without a large lipid core. It's an extremely useful piece of information that if a large lipid core is present, the chance of an infarct occurring during stenting is 50%, 1 in 2. In contrast, if the large lipid core is not present, the risk was only 4%. So as can be seen in the table, the presence of a maximal lipid core burden index greater than 500 was the strongest predictor of peri-stenting MI. It identified a relative risk of 12 for MI occurring during stenting for patients that had that feature. So in summary, near-infrared spectroscopy is very good at identifying stenotic sites that also contain lipid core plaque. This, depending upon how you define lipid core plaque, is about half of stented sites have this and about half don't. The stenotic sites that do have a large lipid core plaque have a much higher incidence, 50% incidence of peri-stenting MI when dilated. So this instrument now provides information about plaques that can be very useful in planning therapy.